All right. Those are our financial disclosures, just so we make sure we get them up there for all of you guys. I'm going to hop right in. All right, HIV Kern County. So good evening, everyone, and thank you so much for being here. We really, really appreciate it. This is HIV in Kern County. Since HIV was first identified as a disease condition, we have had 4,077 Kern County residents diagnosed with HIV. So the first thing I wanted to call your attention to is that our 2023 bar has a little asterisk on there because we have a significant data lag when we talk about HIV. And so we do expect to have more cases added to this. We hope to see this trend that it is less than 2022, but we won't know for a few more months as we're looking at all of the data that is coming in. The red bars represent people diagnosed as an HIV case at the time of their diagnosis. And the blue bars are when they are already in what used to be called the AIDS stage of disease. We now call it HIV stage 3. And as you can see, we've had a significant increase in the number of people diagnosed with HIV and AIDS in the past decade in particular. In 2022, we had more people in Kern County diagnosed with HIV than ever before. And so you can also see that historically, by the time most people were diagnosed, they were already in that AIDS stage disease progression. And as we have come into these more recent years, we are identifying people earlier, and they are still in that HIV stage. Nonetheless, it's still about 1 in 5 of our new diagnoses are diagnosed too late. They're already in their the AIDS stage of their disease progression. So this green line represents our case rate per 100,000 population. So while you can see that in 2022, the number of cases was about 51% higher than the epidemic years, that case rate is about the same as what we were seeing in the height of our HIV epidemic in the 90s. And that's because our population has tripled since then. But let me just repeat that again. Our current case rate is about the same as the HIV pandemic in the 1990s. So just let that sink in for a moment. That's where we are, and we're on an upward trend. This is HIV by age group. So about a third of our cases were diagnosed in their 20s, and another third in their 30s. When we look at our cases by the case rate of age groups, you can see here that historically, let me go back one. Sorry, this is sort of an orange line. It's a little bit hard to tell on this screen. But historically, this orange line, we saw most of our cases diagnosed in their 30s. In more recent years, you can see how the red line has surpassed that, and we're diagnosing people most often in their 20s. And so this may be us catching them earlier in their disease progression, and they are younger, but we're also knowing that when we are diagnosing you when you are 20 years old with HIV, you have a long, long time to grapple with this disease. And so this is something that's especially concerning for us. And we also know people in their 20s may have less access to care, may be less financially stable, may have less, different types of medical insurance, of moving from maybe their parents' medical insurance to their own. And so this is a really difficult transition period for a lot of our young people. We're going to zoom into the last decade or so, and so you can see that the 20-year-olds and 30-year-olds continue to have the highest risk. But when you compare 2010 to 2022, you'll notice that something else in here at the bottom. The rate, when you compare 2010 to 2022, in those 20 and 30-year-olds is about 1.5 times higher than it was back in 2010. If you look at our 13 to 19-year-olds, our teenagers, that rate has increased 11 times. It's 11 times higher than it was back in 2010. And just to kind of further illustrate this, when you look at our 13 to 19-year-olds, nearly half of the cases that have been diagnosed in their teens are in the last 10 years. And so this is important. We are seeing people younger and younger being diagnosed with HIV. And then when we aggregate this is a little bit of a stronger visual of saying, these, the majority of our cases that are diagnosed in their teens are in the last couple of years. So be on the lookout for this. If you've been in the world of HIV for a long time, we really were looking for people in their 30s and their 40s, and that's when they were getting diagnosed. It is getting younger and younger, and we want to be on the lookout for any of our young people who are sexually active. Moving on to HIV cases by gender, as you can see, about 87% of our cases are male, and 11% are female. About 1% of our patients with HIV are transgender. When you look at the rates, you can see that the rate among males is about 5 times higher than females. However, when you look at just females, what you can see is that this rate has increased dramatically over the last 20 years. It is 4.5 times higher than it was. And so this is something that's really important because we are watching the rate in females because we're worried about perinatal transmission. The last time we had a baby born with HIV in Kern County was 2016. The time before that was 2006. And so this is something we're watching very closely because hopefully all of you here also know about the congenital syphilis epidemic we're in the middle of. And what we know about congenital syphilis is that it was predicated by about a year with a sharp increase in syphilis in females. And the very next year, we started seeing congenital syphilis, and we've been trying to get that to go down ever since. And so this is something we at the health department are watching very closely. We want you and our healthcare community to watch very closely because we're trying to very closely follow all of our pregnant persons with HIV. This is HIV by race and ethnicity. And as you can see, Blacks and African Americans continue to have really high rates. I wanted to show you this because when we compare cumulatively since the beginning of HIV, we see about half of our patients have been Hispanic, about 18% Black, and 30% white. When we look in more recent years, in 2022, we're seeing that we are seeing more of our patients are Hispanic, and that about 8% are Black and about 25% are white. But when we look at rates, when we account for a population here in Kern County, you'll see in red that Black and African Americans continue to have the highest rate, a disproportionately high rate of HIV in our community. And even though these rates have decreased significantly, this is awesome that we have seen it decline over the last 40 years, we still see that the rate among African Americans and Blacks is about twice the rate of whites, and the rate among Hispanics is about 45% higher than whites. And so this is something we are continuing to watch. All right, we want to talk about some exposure risk factors. 62% of males with HIV report having sex with other males, and 35% report this as their only risk factor, being MSM is the only risk factor they have for HIV that we know of. But in the last 5 years or so, MSN only as a risk factor, men having sex with men, has gone up to 44%. So we are seeing this more and more often being sort of that singular risk factor. In comparison, about 50% of males report heterosexual activity. And so these are males having sex with females. Only about 14% report only heterosexual contact as their risk factor. So these are males who say their only risk factor for HIV is having sex with females. But what you can see, when we look at just blue, is that that number is increasing. We are having more patients more male patients tell us that their only risk factor is sex with a female. In comparison, when we look at females with HIV, you can see that any heterosexual contact, these are female patients having sex with males, is about 88%. This is a hefty risk factor for our females with HIV. And about 61% report heterosexual sex as their only risk factor. When we look at intravenous drug use, you can see that this is actually a really small proportion. About 31% of patients report that any IV drug use in their history, and 3%, just 3%, report only IV drug use. And so what this is really telling us is that most of our transmission is happening through sexual contact. There's a big mixture of these. You can have sex with both men and women, and you can have sex with both women and have drug use in there. And so teasing this all out can be difficult. But when we look at IV drug use, this is not a huge contributor in it of itself. That's not to say that drug use doesn't contribute to our HIV transmission, but in particular, IV drug use as a mechanism of blood-to-blood transmission seems to be low as the only one. A lot of this is both sex and IV drug use mixed together. All right. Also really important to note is that we ask these questions of all of our patients, and trying to figure out where exposures are happening. And what we find is that about 250 cases, they report no sexual contact and they report no intravenous drug use. And so what you can really see is that 95% of the people who have told us they have no risk factor, we couldn't identify one, this has happened in the past decade. And so this is really important for us in the healthcare community to continue to ask these questions about what those exposures are, building the trust with all of our patients so they can give us an honest answer so we have a better understanding of where transmission is occurring. This is the number of people presumed to be living with HIV in Kern County. So these are people who may have been diagnosed elsewhere, may have moved here, may have lived here all their life. But here in Kern County today, our estimate is that we have 2,425 people in our community today living with HIV. What you can see, because this is based on the year of diagnosis, is that some of these people have been diagnosed in the 80s, and they are still living with HIV in our community. And so this is really important to bring our attention to because, one, these are older adults, but also they've been able to manage their disease for the last 40 years. And so this is a testament to all of the hard work that has happened in our healthcare community, in the public health realm, that we have people surviving. We have patients who are in their 80s living with HIV. And so this is something that is really important to continue to get that messaging, especially to newly diagnosed people. We still talk to a lot of people who, when they get diagnosed, they think their life is over. And the answer to that is that's not true. We can manage this disease, and we know people who've been successfully managing this disease for many, many years. This is what we call our care cascade. And so this is all of the people living with HIV in Kern County, and then we take a look at who has had a lab result in the last 2 years. And so we take that as a proxy that if you've had a lab result in the last 2 years, you're seeking some kind of medical care and you're getting some kind of follow-up. And so we consider them in care and that, they are seeing and taking care of their HIV in whatever capacity that they can. When we look at in blue, their most recent viral load was undetectable. And this means not only are they in care, they are managing their disease, it is not managing them. They are taking care of themselves, they are active in care. If they have an undetectable viral load, they're also not a transmission risk in our community. I'll share this because I used to tell people, that the people living with HIV was a double-edged sword because the more people we have with HIV in our community, the higher the likelihood we're going to have transmission. But that's not true anymore. When we have this proportion of people undetectable, that means they are not a risk to other people. They are not transmitting our community, and we can have more and more and more people living with HIV successfully, and then we can still, at the same time, reduce transmission in our community. So this is our end goal. This is our goal to identify all of the people living with HIV in our community, getting them into care, keeping them in care, getting them to a undetectable viral load, and letting them live that healthy, successful life. Thank you all for your time. And we're going to move on to our next presenter. Sorry. Not managing this very well. All right, next up we have Patrick Salazar. Patrick has 17 years of experience working at Kern County Public Health. He has 9 years of experience working in HIV and STD. Patrick started out conducting HIV testing and linkage to care activities, and he was able to advance in his role to become the program manager by administering the county's HIV and STD programming, which includes, but isn't limited to HIV prevention, Ryan White Part B, HIV surveillance, and congenital syphilis. He was able to secure and sustain funding from the California Department of Health, Public Health Office of AIDS Division to implement the health department's first rapid antiretroviral treatment and PrEP program, respectively. Patrick Lee currently serves as the 2024 president of the California STD/HIV Controllers Association, which represents 61 local health jurisdictions. Patrick holds a bachelor's of arts degree in psychology from the California State University of Bakersfield. Please welcome Patrick.
Good evening, everybody. How are you? Okay, so now that Kim has given us, the prevalence of HIV, I'm going to now take you on the next journey of saying, well, what can we do to help decrease our rates of HIV? And so what I'm going to be talking about, So what I'm going to be talking about today is pre-exposure prophylaxis. So I'm going to talk about how providers can incorporate this into their practices and try to make it in a way where it's not a difficult thing to do. So what I'm hoping to achieve today is I'm going to describe what PrEP is and what is involved in the process of working with patients, learning what PrEP navigation is and what this can look like in practice, and then finally learn how PrEP can be covered and reimbursed for services. So as you can see here, pre-exposure prophylaxis, otherwise popularly known as PrEP. That went backwards. This is very sensitive. So pre-exposure prophylaxis, or PrEP, helps prevent HIV acquisition. So it prevents somebody from contracting HIV. It is often, it was actually first approved by the FDA in 2012, so it's been around for some time, 12 years to be exact. And what we find is there is still more that needs to be done to incorporate PrEP. It is often compared to birth control. So in terms of if someone takes birth control every day to prevent pregnancy, PrEP helps prevent HIV. If not taken, well, actually, let me back up. So PrEP reduces the risk of HIV by 99%. That's amazing. That is really amazing. And it's like, well, why aren't more people taking this? And so some of my colleagues, I look at Ashton right away, who has been working with PrEP for some time. And so we hear a lot of different reasons. It also reduces the risk of HIV through injection drug use by 74%. So the other thing about PrEP, it does not prevent pregnancy, it does not prevent other STIs. And it may be used if somebody is trying to become pregnant or using it during pregnancy or even while breastfeeding to protect the mother and baby. So I know it's kind of hard to see this graphic, but this basically demonstrates how it works if somebody's not on PrEP compared to somebody who is on PrEP. And so what you can kind of see over here on my right is, you know, when HIV is introduced into the immune system, it automatically seeks out our T cells and takes over and just keeps multiplying in our immune system. And sometimes what happens is when that virus takes over, some people can experience an acute HIV infection. So they're experiencing symptoms right off the bat. And so that's what that shows here. It just keeps multiplying. And so over here on the left, what happens is when somebody has the medication, has been taking the medication, what happens is when HIV is introduced into the immune system, the medication prevents the virus from attaching to our T cells and basically does not allow it to take over, and basically the virus doesn't have anywhere to go but die. And so that's how PrEP works. So there are some different types of PrEP, 4 to be exact, and this was not the case a long time ago, back in 2012 when it was first introduced. So the first one was emtricitabine tenofovir disproxil fumarate. That's a mouthful. And then, which was Truvada, which we still have Truvada, and Truvada is used as part of an HIV regimen. Then we also have emtricitabine tenofovir alafenamide, which is known as Descovy. And then Teva, which is the generic form of PrEP. And then finally cabotegravir, which is the injectable PrEP, which is the exciting one that we never thought we would get to. And so the first 3 types of PrEP are to be taken daily. so they're in pill form. And many of these, as I mentioned, not just with Truvada, but all of them are used as part of other HIV treatments. And so somebody who has HIV, it can be used as part of their treatment. The important thing about some of the differences with the different types is, for example, with the first medication, it's approved for both sexual and injection drug use activities, versus Descovy is only used for sexual activity, and Descovy is not approved for use in people assigned female at birth or receptive vaginal sex. And then Teva is used for some of the same activities, such as the first one up there. And then finally, cabotegravir is the long-acting injectable, and it's approved for sexual activity only. So for PrEP effectiveness, for receptive anal sex, the maximum protection reached is about 7 days of daily pill use. Receptive vaginal sex and injection drug use, the maximum protection reached is about 21 days of daily pill use. There's actually no data that is available for insertive anal or vaginal sex. And unfortunately, the time unknown for maximum protection with injectable PrEP is not known at this time. So I wanted to kind of give a little bit of data in regards to PrEP use in our county. And so with PrEP prevalence, as Kim mentioned earlier, the data, there's a lag in terms of the data. And so what we see here on the right is the number of PrEP users. I wanted to kind of give some perspective in terms of how much there is in the state versus what is in our county. So you can see in California, there are 183 people per 100,000 in the state of California that have been prescribed PrEP. And so what that means, that's about 64,424 users. Versus in Kern County, there's 81 people per 100,000. And so what that equates to is about 547 people. That's a very low number compared to what it is in the state. The number over here on the left, which is PrEP to need ratio, what this demonstrates is that, for the year 2022, the PrEP to need ratio reflects the number of PrEP users over the number of people newly diagnosed with HIV in 2021. And so what this means is for California, 13.7 persons were using PrEP for every one person newly diagnosed with HIV. And then if you go down to Kern County, it's only 3.0 persons per PrEP, are using PrEP for every one person newly diagnosed. So this is just demonstrating that there is a need for more people to be on PrEP. So as part of doing PrEP initiation and management, the following information is going to be based on how we at the health department prescribe PrEP, and we have some of our providers in the room that are awesome at prescribing our PrEP and working with our patients. So something that should be done is obviously a sexual health assessment. And what this is going to facilitate is having a more comfortable relationship with providers. And so a patient needs to feel that they can talk about their sexual activity with their provider and have that open conversation in order to find out what their risk is for HIV. And if the patient is not able to have those conversations, then you're really not going to get very far with the patient, and they're not going to trust you and opening up to you as a provider. And so that sexual health assessment is really going to be that key point in time where you have that dialogue. And that the next thing that's very important is assessing for signs and symptoms of acute HIV. And so in your folder, there is actually a informational sheet that talks about what acute HIV is, because it's very important to identify those types of symptoms in patients. And they do mimic flu symptoms and things like that. And then our program at the health department is set up to allow someone to go to have same-day PrEP. So they can leave with their PrEP prescription that same day. They actually receive medication in the clinic. And so it just makes it easier for them so they don't have to maybe wait, and potentially they might not come back for whatever reasons. People have a lot going on in their lives. And so we just try to make sure if all the baseline testing that's done comes back normal, then that person will be able to stay on PrEP. And so there's a number of different labs here you can see. It's just confirming their HIV status, renal function, and mind you, some of these are different across the different types of PrEP. And so some of these are not done with, for example, cabotegravir, which is the injectable PrEP. So part of the management is scheduling quarterly follow-up visits. And this allows, again, the patient to receive ongoing testing, especially when it comes to STIs. But it also allows the provider and the patient to just continue to have that dialogue on what is going on in their sexual life. And so it's just that way of also keeping that good rapport with the patient. And then just something to mention here, that the lab frequency and the type is going to differ across patients. Obviously, patients have different things going on, especially if they have any issues with like renal function and things like that. In your packet, I do want to mention, we did include in your folder a resource that was developed by the AIDS Education and Training Center, which one of my colleagues is here that's going to speak, Tom Donahoe. It tells you everything you need to know about prescribing PrEP, all the labs that go into it, just everything you need to know. I thought it was a really good resource. One of the other things I wanted to mention was something that's called PrEP 211. And so this is an off-label use of PrEP. And so I mentioned this off-label use only because it could serve as a potential option, depending on if there are any adherence issues with patients, or if they report having, we know that some patients have issues taking daily pills. I know me, for one, I have issues taking medications daily, period, but it's all about finding what works for the patient. And so what PrEP 211 is, basically it's referred to as on-demand PrEP, intermittent, non-daily, event-driven, or off-label PrEP use. And it's basically the patient takes 2 pills 2 to 24 hours before sex, 1 pill 24 hours after the first dose, and 1 pill 24 hours after the second dose. And so it's only been studied as an alternative to daily PrEP for gay and bisexual men or other men who have sex with men. There is also an informational sheet included in your folder from the California Department of Public Health that talks about what PrEP 211 is. Oh, and I should mention it is not an FDA or CDC approved regimen, but it is a regimen that exists and that other clinics and providers throughout the country use with patients. So the other piece I want to this one is a very, very important piece, which is the PrEP navigation. There is a lot that goes into having someone understand exactly what they're getting into, because people have to follow the regimen to be on PrEP. And so I have some of my staff here that are actually PrEP navigators or that have done PrEP navigation, and they know exactly what goes into, how much goes into getting, helping someone get on PrEP. And so this navigation piece can be anybody that is in the clinical office. It could be, it can be someone who's non-clinical, so it could be an MA or LVN, someone that's knowledgeable, that has knowledge about financial resources, what is available in the community to help cover PrEP. Because at the end of the day, there shouldn't be a cost to PrEP, because that's the whole point of breaking down barriers to get people on PrEP, is that there should not be a cost to it. The great thing is, if it's a good indication for somebody, the provider team can, the provider can say, okay, this person is interested in PrEP, and somebody else comes in to explain everything to them, what goes into it. And so part of what's going to be shared in the slides is some resources that are available, which I'll touch on shortly. And the important thing I want to say about this is PrEP is a voluntary thing. So we have to do everything that we can to make it easy for folks to get on PrEP and stay on PrEP. And the way this is also going to happen is if at the provider's office, it starts all the way at the front and goes all the way to the back. So your people that are your front desk people, it's important for them to know this information, because it has to be presented in a very non-judgmental way. We never want to make people feel like they're being judged for their sex lives or injection drug use. So here are some of the ways that PrEP is paid for. Medi-Cal covers everything, which is great, even the medications. And so with the expansion of Medi-Cal, we were excited about that, because it just means that more people are eligible to be on PrEP. There are different PrEP-associated costs, especially with certain commercial and employer plans. Sometimes there's deductibles. So it's a lot for somebody to take in. And so someone needs as part of that navigation process, needs to be able to explain a lot of this to somebody. PrEP app is another option that's provided through the state of California. It's called a PrEP app, PrEP Assistance Program. And so it's like payer of last resort, but this is meant for folks who are maybe underinsured or uninsured. And so this will help cover the cost of any PrEP-associated costs, all the way from the visit to the labs and things like that. It is income-based, and so we need to be able to make sure they qualify. But at the health department, we're an enrollment site, so we can help with some of that. And then also drug manufacturers also have programs available. So here are some of the resources I just wanted to share, the most important ones that I saw in terms of what those clinical guidelines are. The Consultation Center at University of California, San Francisco is a great resource for providers that have clinical questions. There is an HIV PrEP navigation certification program. That's a mouthful. So anybody can be certified as a PrEP navigator and learn about all these different things that go into helping someone get on PrEP. And then finally, that PrEP navigation manual that I spoke about, it's a very, very good manual. I encourage you to check it out. And then the last thing I'm just going to end with is a little short video from greaterthanaids.org that just kind of shows, talks about, what it's like to be on PrEP, and has some really great short information.
Hey, if you're sexually active, hold on for 1 second, stop. You're gonna wanna watch this video. So PrEP is this amazing opportunity to really take control of your own sexual life I can take a pill a day, I can take an injection every couple months, and I can take this HIV fear and anxiety away. PrEP is pre-exposure prophylaxis. It is HIV medication that people who do not have HIV can take, and it prevents HIV infection. PrEP is extraordinarily effective, 99% effective in most cases when it comes to sexual transmission of HIV. It's such big news because it allows people to really express themselves sexually and also allows for a really significant amount of control. It's not about the heat of the moment. It's about planning in advance, whether they want to do daily PrEP, injectable PrEP, whether they want to do episodic or 2-1-1 PrEP, or they want to use a condom or put condoms and PrEP together in a way that makes sense for them. The beauty of PrEP is that you don't have to stay on it forever. So, people's lives change depending on what's happening. If you're having more sex, more encounters, it may be the right time for PrEP for you. If something changes and you enter a monogamous relationship, you may choose to stop it, or you may not. Really, it's up to you. So if you think you need it, if you see yourself in anything that I'm saying today, or you just don't want to worry so much when you have sex in general, PrEP is a great option. And if you need help, there are lots of ways to find it.
So that was just a quick video that I wanted to mention because it's an easy thing for people to do, and we can make it easy for them to have access to it. So thank you very much.
Alrighty, next up we have Dr. Christopher Lyon. Dr. Lyon is certified in both emergency medicine and EMS medicine. He is the public health officer and the EMS medical director in Kern County and works clinically as an emergency room physician in Bakersfield. Dr. Lyon is a reserve deputy and medical team leader for a law enforcement SWAT team as well. Please welcome Dr. Lyon.
Well, good evening. Thank you, everybody, for being here. I appreciate you taking the time to be here. It's been quite a privilege to be the health officer for Kern County, and it's been really amazing trying to bring together our emergency medicine colleagues, as well as everybody in the community and community practice to help try to address our HIV epidemic. So I'm going to go through treatment and specifically rapid treatment of HIV. We talked a little bit about the numbers. We've talked about prevention. But now, when it comes to diagnosis, when should we treat patients with HIV? And I'm going to go through some basics that you probably all may have some background in. But as an emergency physician, I like to kind of bring things back down and why are we doing these things and the way we're doing it. And things that we think have been what we do all the time have not been that way and have changed fairly rapidly in the recent past. So antiretroviral therapy, ART, has led to dramatic reductions in HIV-associated morbidity and mortality. So this is amazing, right? So we now have a treatment for HIV. We've had it for a long time now, but people don't really understand that in the public as much. And in data that's been presented in a number of different settings, resource-rich settings, life expectancy of patients with HIV with access to early ART is approaching that of the general population. So again, this is also about communicating to our patients that if you've been diagnosed with HIV, it's becoming like you have hypertension or diabetes. It is a treatable infection that there's a high likelihood if you stay on your medications you'll die from something else, not HIV. You know, a long time ago, it was thought of as a death sentence. It's not that anymore. These drugs are highly effective. You all know that. So reducing HIV-related morbidity and mortality, irrespective of the degree of immune suppression at treatment initiation. So ART should be recommended to all individuals with HIV infections. But again, why? Why are we treating this the way we are? Because viral suppression, as measured by HIV-1 RNA level, can be driven below the limits of detection. So we've talked about U equals U, right? So if your viral load is undetectable, then you cannot transmit HIV. Immune reconstitution is measured by an increase in or maintenance of CD4 cell count. So your body's immunity is functioning. Reduction in HIV-associated complications, including age-related and non-age-related conditions, reduce transmission, reduce perinatal HIV transmission, and again, reducing morbidity and mortality from causes not related to HIV. So these are all incredibly important parts of why we treat people with antiretrovirals. But there's been controversy. When should we start people on medications? You know, we've dealt with this just in the past few years with our testing program. There's disagreement in our community. Disagreement when I call and talk to a hospitalist about, we need to start this person on ART now, we diagnosed them today. And there's disagreement because in the past, there's been hoops that had to be jumped through. You have to have confirmation. You have to have X, Y, and Z lab. You have to have counseling to make sure that they're going to be compliant. But do we need to wait for all that? Do we need to wait for all the resistance testing to return? In my opinion, and based on everything I see, we don't. So rapid ART means shorter time to viral suppression. It increases retention and care and reduces HIV transmission. But is it safe? That's the argument that I've heard about we need to wait for X, Y, and Z lab. We need to wait for these things. Everything that, all the guidelines that I've been reading and review recommend rapid initiation because it is safe. The pre-existing resistance to currently recommended regimens for rapid initiation is rare. Very, very few people, only 1 of 149 patients in this New York City study required a regimen change. Most designated regimens for rapid ART initiation are the same regimens that are recommended for initial treatment. These regimens are well tolerated and effective, and the likelihood of drug resistance is low based on the current prevalence of drug resistance. Okay, well, how rapid are we talking? So you'll see everything up to 72 hours. And we still have a lot of improvement that we can make, but our goal should be same day. We should be starting people immediately on antiretrovirals unless there's a clear contraindication. Rapid ART initiation may reduce delays and improve viral suppression rates in people with HIV. Rapid or same-day initiation, which is preferable, or initiation within 3 days of a newly positive HIV test is the strategy endorsed by the WHO. Again, just reiterating, the WHO recommends rapid ART initiation should be offered to all people living with HIV following a confirmed HIV diagnosis and clinical assessment. And ART should be offered on the same day to people who are ready to start. This is from the Consolidated Guidelines on HIV Prevention, Testing, Treatment, Service Delivery, and Monitoring Recommendations for a Public Health Approach. So, where can this happen? It can happen in your clinic. You don't have to be an HIV specialist. This can happen in the emergency department. This can happen in internal medicine clinic, family practice clinic. Anybody that is providing care to patients can do this. San Francisco published these two studies showing a citywide initiative to optimize antiretroviral therapy initiation, time from HIV diagnosis to care, antiretroviral therapy, and virologic suppression decreased across all affected groups to varying degrees. And treatment for HIV infection can be started on the day of diagnosis without impacting the safety or acceptability of ART. Same-day ART may shorten time to virologic suppression. So how do we do this? There are lots of different toolkits out there. This is all freely available online and available for your reference. This one is from the CDC, but there are plenty others available. Well, what about emergency departments? It's chaotic. You know, we're trying to move people through, but this is important. This is really critical to people and their long-term care. So Doug White, who is a friend of ours that we've worked with pretty extensively on a lot of the projects that we've done here in Kern County, published this study. And this looked at rapid ART in the emergency department. And this was done in Oakland at Alameda County. So they were patients that had rapid ART initiation were more likely to keep their first appointment. An initiation of rapid ART for ED patients with HIV infection is feasible, well accepted, and safe, and may be an important facilitator of linkage to care. So yes, we can do it. What did they do to screen patients? This is available in their article and basically goes through different risk factors. Sorry, it doesn't look like it presents great, but it is in your packet and it is available online. There's also more resources available on the AIDS Education Training Center website. So that was kind of the overview of treatment. And I'm going to focus more now on what we've done here in Kern County. You know, it was an opportunity that I saw after becoming health officer that I could bring together public health and the emergency department. And so this was also, at the same time, our health department was funded by a CDPH in 2019 through a grant funding for a rapid art demonstration project. We had just finished developing a prep program in early 2019, which continues to this day, as Patrick discussed. So rapid art was the logical next step in bridging gaps in HIV prevention and care. And so this was primarily in our clinic at Public Health, but that was a core piece for our emergency department aspect as well. So our initial goals for this program were initiation within 5 days of preliminary positive test results. And we weren't waiting for confirmations. We're trying to do this as soon as possible. And then our goal was to have a follow-up with HIV specialists within 30 days. Because our clinic is not meant for long-term care. We're a stopgap to try to get people on the medications and fill in until they can follow up for long-term care. Out of 115 referrals over the year and a half of the project, 70% were newly diagnosed HIV patients, but 26% were patients who had been previously diagnosed and were out of care. Rapid ART was an opportunity to bring them back in care and hopefully keep them in care long term. And of those, only 4% did not confirm. Of the newly diagnosed patients, about a quarter were identified by public health, which has had routine HIV testing for all persons seeking reproductive or sexual health services. Another quarter were identified by emergency departments who were performing routine opt-out testing, and some of which have since implemented rapid ART. But the largest group came from our community-based providers, 43%. We hope that all of our community providers consider offering rapid ART when patients come back positive. You already have an established relationship with them, you tested them, and they're much more likely to follow up with you and stay on treatment rather than being referred out. So, opt-out testing. This is a Dear Colleague letter that Dr. Jacobson and colleagues wrote to support the use of opt-out testing in emergency departments for testing for HIV. This also includes Hep C and syphilis. And they support this as a method of addressing these three infections in California. What we did in the ED was test anyone that came in that was 12 or older, and I think that was really important considering what Kim's slides were showing about the increasing prevalence of HIV in our teen population. This was done on patients that did not decline testing, who were already getting blood drawn, and this was run only if they had not had testing within the past 12 months, although the providers could go ahead and manually order if they felt the patient had high risks. And what I thought was really astounding of just looking at the 20,000 foot level, when we looked at the test positivity of all these thousands and thousands of tests we were doing, roughly 8% came back positive for Hep C, and 5% of all the blood tests came back positive for syphilis, and about 1% for HIV. So these are staggering numbers when we're doing huge numbers of tests in the emergency department. So who are we going to start on medications? So we have our new diagnoses, or presumed new, because most of the emergency department tests were going to have a preliminary positive. So these patients take a little bit more thought in terms of when we're going to start them and whether there's risk factors that there's a contraindication. The out-of-care patients are really an opportunity to help patients return to care and identify challenges of being in care and offer solutions to improved retention. But these patients already have possibly a regimen that they were already on, that we can just restart them on what they were on in the past. The newly diagnosed patients, we have to have a discussion about their risk. Do we feel that they have risk factors in talking with the patient that this is a true positive? Now, that being said, the current medications that we start people on are pretty low risk. So in my mind, it's usually beneficial to start the patient. There's very few times I would say it's not a good idea to start people preliminarily if they don't have any true contraindications. But it is a shared decision making with the patient. You know, and I've had some people that want to wait for the confirmation, and some people want to start now. So what are we using in the ED? Again, I'm not sure how well that present, but we developed a flow sheet with Dr. Jacobson, who is the chief of the STD control branch at CDPH. And essentially, this makes it simple for an emergency physician to say, hey, I'm going to start you on HIV medications, and I feel comfortable doing that safely. So it goes back to what we do as ER physicians and nurse practitioners and PAs. Looking at the patient and determining whether they're sick or not sick. So if they're all in the green, they're good to go. There's no issues with starting on medications. We'll send all the labs that we need to have for their follow-up, but we're going to start them on ART on the spot in the emergency department. Now, if they have any vital sign abnormalities, which are in the red box at the top, or if they have any complaints or physiologic changes on the purple or blue boxes, we're going to take a pause and evaluate those risk factors further. So that may mean that I'm going to call Dr. Jacobson, hopefully not at 2 a.m, and get her input. Or I'm going to call some of our other colleagues in the community that are here with us today and talk to them about, is this safe to put this person on ART today? Or do they need to be admitted and get further workup to rule out anything that could be harmful to the patient with starting the medications? But again, we implemented this, and I feel like it was very effective. I know Dr. Burson used it at Memorial when we implemented there. They were our first ER to go live, and it has been successful in allowing our ED practitioners to start people on medications and feel comfortable doing it. But there's still challenges with this. So this is GoodRx. You pull up and see how much it costs to start people on, this is, I'm probably not supposed to use brand names, but Biktarvy, because I can't pronounce, and it's expensive. And a lot of the insurance, may require pre-approval. There's all the hoops that you jump through with medications with this kind of cost. So it doesn't do anybody any good if I start you on Biktarvy in the ER and you go home and you can't take it the next day because it costs $4,000. So we have to have a plan of what we're going to do to ensure that they can continue the medication, not just I start it and then they stop and go find somebody else that's going to take that next step. So what are some of the ways we've done this? I think the easiest way would be if we could just have our ED or hospital-based pharmacies dispense the medication. But this has become increasingly difficult to dispense medications from the hospitals, especially most of the hospitals no longer have outpatient pharmacies. And there's so many regulations with the Board of Pharmacy to be able to actually send people home with a bottle of medication that this is really challenging. It is doable. It is possible to do. At Adventist Bakersfield, we were able to do it sort of. So the compromise was that on Fridays through Sundays, we could give the patient a 3-pack, 3-day supply of medication so that they could get to the next business day, hopefully to then come in and see our colleagues at Public Health in our clinic or one of our other clinics in the community to then take that next step to be able to get their medication long term. So the other way to do this is starter packs. That's a whole nother administrative challenge. Some administrations are okay with it, but having pharmaceutical supplied starter packs that you can give to the patients, that's what they did with the Alameda program, and that was a successful method to do that. Meds to Beds is a program that some of the hospitals use where they contract with a pharmacy to actually bring the medication to the patient while they're in the hospital or in the emergency department. The other way that I haven't seen really work out perfectly is partner pharmacies where they are going to go and pick it up, because again, it's the cost and the hoops of jumping through with pharmacy, with insurance to make sure that they can actually get it. So the best ways, I think, are either getting your hospital to support dispensing the meds, or most likely the starter packs are the best ways to make sure that they can continue the meds until they can get into public health or the community clinics or ID to be able to afford the medications. And we have ways of working with the patients and working with different payers to make sure that everybody can be on medications. So 27% of newly diagnosed patients would have remained undiagnosed without routine opt-out testing. 78% of patients identified in the ED were linked to care or pending care appointments. 32% received ART within 5 days, and 59% received ART within 14 days. So clearly not as rapid as what we'd like, but I think we're moving in the right direction. We have improved the access to care. We've improved all the different pillars of treatment. So prevention, testing, and treatment are the cornerstones of efforts to end the HIV epidemic. Identifying that rapid ART is safe and effective, and being willing to take that step for patients to start it. At this point, I would say that rapid ART is the standard of care. So we've come a long way in Kern County by expanding our PrEP, our testing, and our treatment services. However, we still have a long ways to go. But I think with all of our partnerships with everybody in the room, we can take this further and drive down the time to initiation of treatment and help our patients. So thank you very much. I appreciate, again, everybody attending, and I hope to see you at our next symposium next quarter.
All right, next up is Ms. Ashton Chase. She is a board-certified nurse practitioner and HIV specialist at Clinica Sierra Vista 34th Street Community Health Center. She completed her Bachelor of Science of Nursing at Liberty University and then earned her Master's of Science in Nursing at South University. She is certified by the American Academy of Nurse Practitioners as well as the American Academy of HIV Medicine. She is passionate about providing care to our most vulnerable populations, and when not seeing patients inside the clinic, she provides care for the homeless individuals in Kern County, performing street medicine rounds. She loves anything butterflies, beach, air, and tropical vacations. Please welcome Ashton.
Okay. Hi, everybody. Thank you so much. All right, so today, of course, HIV in the primary care setting. I do provide whole person HIV care at our 34th Street Community Health Center. So today, our learning objectives are as follows. I really just want to complete an intake for a newly diagnosed patient with HIV with proper medical, social, and historical data, and recommend appropriate labs, diagnostic imaging, and vaccinations. So I did bring a little case to you, kind of what we see on a day-to-day basis of a patient that will present to a clinic and how we look at this patient and get them started to care. So an 18-year-old bisexual male presents to the clinic after being seen at a local urgent care for flu-like symptoms, rapid weight loss, and fatigue for 1 week. He's had one male and one female partner in the last 3 months. He does not use barrier protection, denies any past medical history at this time. He was screened for HIV and 2 days later informed that his HIV screening test was reactive as well as HIV-1 antibodies were positive. He is treatment naive and presents to clinic today. So he does present to us with his positive HIV fourth generation test. So what do we do next? So what do we need to know? What type of HIV test was performed? Did he get a fourth generation test or did he get a point of care test? When was the initial diagnosis? Is this acute diagnosis, a chronic, or re-engagement to care? Any history of any opportunistic infections, and any history of previous HIV testing. So when they come to the clinic at first, the initial labs of HIV is a lot, especially when you're doing whole person HIV care. So most important test, having that fourth generation test and our viral load. CD4 count, of course, our lymphocyte set is very important, as well as knowing kidney function, renal function. But getting a viral hepatitis panel is also very important because we want to make sure that that patient does not have hepatitis B or hepatitis C. I do hepatitis C treatment as well at our clinic. More labs to come, of course. We live in Kern County. Getting a cocci serology is absolutely important, as well as screening for tuberculosis. I do get some baseline MMR, CMV, toxoplasma, but number one right now is syphilis, making sure we screen all of our patients for syphilis. Of course, we're talking about primary care, so we want to do the lipid panel, thyroid panel, hemoglobin A1C, getting a urine, and then screening for our STDs as well. And there's some labs down here, a G6PD, if their CD4 count is less than 200, and we're going to start our patients on Bactrim for PCP prophylaxis or PJP prophylaxis. And I don't use abacavir, but if we were using it, an HLA-B5701. In our clinic, we really do repeat our fourth generation test because we have had a high rate of false positives or patients that present to our clinic that have said, my HIV test did come back reactive and it was a false positive. So this is an example of an HIV test that did come back. The screen was reactive. But if we look at our antibodies, our HIV-1 and HIV-2 were both negative, but the screen was positive. This patient was in fact informed that they were HIV positive and was pretty much a day from taking her own life. So it's very important that we do repeat these tests to make sure and ensure that these patients are actually HIV positive because it is a life-changing diagnosis. So we do ask HIV-specific questions. So what brought you in for testing? Are you asymptomatic, routine testing? Were you informed by your partner of a positive test? And I also ask, do you know your last viral load if you are HIV positive or when you're returning to care? When's the last date of the labs? I'll have some people come in and the last labs that presented were from 2022, 2023. I'm like, let's make sure to repeat. What is their lowest CD4 count? Because after being off of ART for quite some time, our risk of going back to a low CD4 count is very high. Any history of, again, opportunistic infections, and were they symptomatic? Any fever, weight loss, chills, night sweats, GI issues, or oral candida, or oral yeast infection? Any past medical history for our patients? We are now providing whole person care. So any current medications are taking, any prescribed and over-the-counter medications, we want to make sure there is no drug-drug interactions with the current medications that we are putting them on. Any surgeries in the past and OB history. Now, bictegravir or Biktarvy is indicated in pregnancy, and I do treat pregnant HIV patients as well. And family history. Social history. I love social history. Let's talk about sex all day, okay? So it's the 5P approach, but for me, it's the 6th P that is the best. So I always talk to my patients, and I was like, all right, I'm going to ask you these questions. I ask every one of my patients these questions, so let's talk about sex. So partners, do you have male, female, or both partners? And how many partners have you had in the last 3 months? Past history, have you had any history of any STI infection? And practices, any alcohol, drug use, and how do you use your drugs? Do you smoke it? Do you snort it? Do you inject it? I'm checking for risk factors, especially hepatitis C. It's very prevalent right now as well. And pregnancy, how are you protecting yourself? Are we trying to get pregnant? Are we using any Nexplanon, condoms, etc.? Protection, of course. And how often do you use condoms? All the time, intermittently, or not at all? And then PrEP, of course, if HIV negative. Any alcohol or drug use, any history of hepatitis C, was it treated? Tobacco use, including vape, And financial. Housing or unhoused, we want to refer you to our HOPWA program or Ryan White Services. And I do ask employment as well as part of their social history. Antiviral history. For any newly diagnosed, any history of PrEP use, any Descovy or Truvada, or cabotegravir. Why I ask why they're on PrEP is because you can build resistance to those medications. So we want to make sure that if they were using PrEP before, we obtain a genotype to make sure they didn't build resistance to the medications that they were prescribed. Any past history of ART use? What were you using in the past? And if they're like, oh, is the purple pill, the yellow pill, the green pill? Did you have side effects of nightmares? So we have a nice big screen at our clinic. It shows every ART medication. So I'm like, point to which one you were taking in the past. Any history of intolerance or known history of resistance? And are they currently using any ART? Any side effects that you're incurring? Any barriers to your regimen, such as financial? Or how is your adherence or compliance to your medications? Resistance testing. When do we order resistance testing? So any viral load that's greater than 200 copies, I will get a resistance test. But the resistance test is not reflexing right now until it's greater than 500. So anywhere from 500 to 800, I will grab a new genotype test to make sure that the patient did not build resistance. And sometimes it's just adherence more than anything. Give them 30 days and tell them, come back to the clinic, let's repeat your test in 1 month and make sure your viral load is going down. Now we talk about whole person HIV care, which also means all of our preventative screenings. So I try not to overwhelm my patient in the beginning, but we chop at this little bit at a time. So cardiovascular disease prevention, when we are now putting patients on statins a lot earlier. HIV is an infection of inflammation as well. If we look at the Reprieve trial, it's bringing down that inflammation. So what I do now, instead of using the basic ASCVD, I increase the patient's age by 10 years and add that they're a smoker. It does give you a better risk of their 10-year ASCVD risk and putting them on a statin. Lung cancer screening, as appropriate. Breast cancer screening, we start at age 40. Bone density screening, because old generation of ART did have effects with bone health. TDF especially, so I start at age 50 or postmenopausal women. Cervical cancer screening guidelines have changed for HIV positive women. It was Q1 times 3, and now it has changed to Q3, but with HPV testing. Colon cancer screening, as well as for age-based, and then anal cancer screening. No official guidelines, but I do start at the age of 35, and I will do it annually at this time. And if any HPV or abnormal cells do come back on the anal pap, I refer them to colorectal surgery for a biopsy. Vaccines, the bane of our existence. I like to thank my wonderful medical assistants and nurses who take care of this for me. But we do want to make sure our patients are vaccinated against any and all, especially Hep B, Hep A, and pneumococcal. These are the easy ones. The hard ones are here. Okay. And then it really does take a village to take care of our patients. So the patient's always at the center of our care. And we're lucky enough to have Ryan White program and have nursing staff and medical assistants at my clinic as well as pharmacy. So, of course, the provider, case manager, behavioral health, all newly diagnosed patients, I refer to our amazing marriage family therapist who does a great job and is there for the patient as well. We do have pharmacy on staff, and we do link our patients to care with ADAP, especially when the medications aren't covered. Our Avita pharmacy does a really good job with taking care of that for us. So back to our case study. So he did come with a 4th generation HIV-1 antibody, was positive. When he presented to me, it was 1.58 million copies of HIV. CD4 count was 187 and 11%, putting him at a diagnosis of AIDS. He was leukopenic on presentation with white blood cell count of 2.7 and neutrophils were low as well. He was non-immune to Hep B, which we started at the clinic. Hep C, it was negative, and Hep A was immune. He was tested for oral rectal chlamydia and gonorrhea and noted to come back with gonorrhea and chlamydia, rectal, and urine were positive. He was treated with doxycycline twice a day for 7 days in Rocephin, 500 milligrams times 1 in the clinic. He was started same day, a rapid start at the same day I first saw him, with bictegravir and Bactrim DS for PCP or PJP prophylaxis. And he was followed up in 2 weeks. So when he did present back to me, by month 2, his viral load was not detected. By month 3, his CD4 count was 249 and 14%. He still remains undetectable with a positive 10-pound weight gain with no complaints of side effects, and continues to follow up every 3 months. So as we know, HIV is a chronic, manageable disease that can be managed in the primary care setting. It's about knowing the past and the present so we can truly prepare for our future. Our oldest patient right now is 87 years old, and he's thriving. So HIV continues to evolve, and having a great support system is vital for the patient and the care team. And remember, you does really equal you. Undetectable levels of HIV are untransmittable. Here's my contact information, and it really does take a village, and I'd like to thank my team for all they do. So thank you.
Thank you, Ashton. Next up, we have Tom Donahoe. He is the director and the principal investigator for the Pacific AIDS Education and Training Center, PAETC, in the Los Angeles area, the associate director of the UCLA Center for Health Promotion and Disease Prevention, and a professor of family medicine at the David Geffen School of Medicine at UCLA. He has worked with the PAETC since 1990 and served as volunteer bilingual faculty and helped organize over 20 HIV/AIDS training programs in more than 15 states in the Republic of Mexico. In August 2006, he received the Ryan White CARE Act AETC Leadership Award in Washington, D.C. for his work on the U.S.-Mexico border AETC steering team. His work includes training on linking and keeping HIV patients in care, especially highly mobile migrant populations and HIV patients in immigration and customs enforcement custody. Tom's HIV-related areas of interest include methamphetamine, mental health, emergency departments, rapid art, aging, oral health, hookup apps, and workforce development. Please welcome Tom.
Hello. Thank you for that. Whenever they put my degree up, I always feel like people must be confused. Like, why does he have an MBA and he's working in HIV? So I'll tell that story really quickly before I get started. And then I'll talk about some transitions as well that are happening at our AIDS Education Training Center. So I was an investment banker working in New York City in Wall Street, making more money than I make now. But I have no regrets, so going into HIV. And so if you're out there thinking, like, you know, if you're not yet working in HIV and you're thinking about HIV, I strongly encourage you to pursue it as a field. If you talk to most people, I think Ashton demonstrates it through her glowing joy of you know, it's something that will take you in. So I was working on Wall Street, and one of my friends, my best friend from junior high school and high school, she was always talking about protecting me. So I was a gay man in New York City in 1987. And so it was always about protecting me. We should have been talking about protecting her. So she got chronic yeast infection. She was going to provider after provider. Finally, she couldn't walk up the stairs in her condo. And she went to the emergency department 3 or 4 times. Nobody thought about an HIV test. So I was actually with her in 1987. She said, will you come be with me? They did an HIV test and they're gonna call me with the results. And so in 1987, Chris, her name was Chris with a K, found out that she had HIV over the telephone, and not to get pregnant, to get her affairs in order. She was told she had 6 months to live, and there was nothing she could do. to improve her health. So she had the support of a family, she had good trust in and access to the medical system, but there were no drugs to treat HIV at this time. So I got to live through I never thought HIV would impact me personally. I thought I'm protecting myself, I'm not gonna really have to deal with this. I volunteered, I did my part, but I was with her for 3 years dealing with HIV from 1987 to 1990. It was a horrible, horrible disease then. So today, Chris would have a family. She'd hopefully get diagnosed in an emergency department in Kern County and get rapid ART from Dr. Lyon. But it's a totally different world today. So when she passed, and I was with her when she passed in 1990, I said with my MBA that I would work 2 years in HIV. And so now I'm also telling you tonight that I'm retiring in June after 34 years working in HIV. But I'm turning it over to good people, and so I'm going to tell you about some of those good people. And I've received a few phone calls. I'll tell you one more story. I've been working 34 years, some of the work I'm proud of. Thank you very much, Kim, for that intro. I have been to more than 20 states in Mexico doing trainings. I'm very proud of that work. A Mexican physician came into my office in 1993 and said, you need to do something in Spanish. You need to do something with Mexico. He was very passionate, and so we ended up doing all of that work. Lots of awards, et cetera. In 2018, I was helping a colleague with an emergency department project in Arizona, and I got a phone call from somebody who was saying, look, I just met one of your colleagues. I was at a training in San Luis Obispo, I think it was, and I'm just been made the health officer of Kern County. I'm an emergency medicine physician, and I really want to do HIV screening. And so when you work in my field, you never get phone calls like that. I remember pulling over and saying, what's your name again? Chris Lyon. Okay, don't go anywhere, okay? Don't leave. We're gonna exchange cell phone numbers, and I'm gonna help you get resources, right? Because you need to bring in resources, but you have the motivation, and that's the number one thing. And he said right off the bat, that first phone call, you said, I also want to screen for syphilis, because syphilis is a big problem here, and why are we just screening for HIV? We should also be screening for syphilis. I can tell you that phone call changed my focus for the last 6 years, also changed the focus of the state of California, and I'm going to talk about that a little bit too. I mean, we now have 4 emergency departments doing or starting to do screening for HIV, syphilis, and hepatitis C. And we were hoping for $30 million. We helped secure $15 million. Also because of that phone call, led to our participation working with someone in the state assembly to get $15 million that's helping to fund those 4 sites. But if you could just give another round of applause to Chris Lyon, because and I told him, I think the second thing I said was I'm going to look for this colleague of mine who I thought was in Africa at the time, Kathy Jacobson. She was our medical director, and I think that led to her being the STD branch chief as well, because of the work that was done in Kern County and kind of making the case to the state that every emergency department should be doing this. So you just heard from Patrick talking about PrEP. You just heard from Kim about the epidemiology of Kern County. You just heard a great talk from Ashton about primary care and HIV. So I'm kind of here to say, where do you go if you want to do these things? And where can you get help? So my talk is using the Pacific AIDS Education and Training Center. I'm the Los Angeles area. So what's the Los Angeles area? Sounds very Los Angeles-centric. So that includes Kern, Ventura, Santa Barbara, and Inyo counties. I have Kern underlined because we spend a lot more time in Kern than we do in those other counties, because we want to go where the health disparities are the largest. And so that's how the EDSP, Emergency Department Screening Program, that's HIV, syphilis, and hepatitis C, that's how they funded the sites as well. And so there were only, I believe, 2 counties that got 4 out of 4 applications funded, San Bernardino and Kern, because that's where the health disparities and most unmet need exist. So we have a special place in our heart for Kern County. It's, it's not a million miles away, but it is far away. And I was just telling the woman who's going to take over for me, Sandra Cuevas, as director, this morning I was saying, in retirement, I'm going to be retiring and I'm going to come back 40% time. And I said, definitely allocate me Kern, so whatever it takes to come and work with Kern County. We have our own disclaimers. These are my learning objectives. You'll be able to review the types of training, technical assistance, and resources offered by the AIDS education and training centers in general, but with a focus on our PATC and California's rural counties like Kern. You'll be able to discuss possible HIV-related training needs in Kern County, identify best practices already being implemented in Kern County, and use PATC and other HIV-related training resources moving forward. So this is the AIDS Education and Training Center. I'm part of the Pacific, which includes the Hawaiian Islands and the Pacific jurisdictions. I work a lot with our colleagues at the South Central AETC because we have a U.S.-Mexico border project. You probably heard that at the beginning. I have a special interest in migrants, and especially now we have 9 million people in the last 18 months who've crossed the border. Many of them have HIV-related needs. Maybe you've seen some of those persons here in Kern. I was just with President Biden's new Office of National AIDS Policy Director. The media call him the AIDS czar in El Paso. And we crossed the border and went to our colleagues, HIV colleagues in Juarez, to a needle exchange, to a program for transgender sex workers. But there's going to be a lot of new need around this issue of immigration and HIV. So this is in your handouts. You don't have to write any of this down, but I think it was in the pre-test that I took on the computer walking in. So we have different toll-free lines as AIDS education and training centers. The first there is a warm line. Why do we call it a warm line? Because we make a commitment to get back to you within 24 hours. Often the question is about something like iris, or it could be related to something that requires consultation with the pharmacist. So we call it a warm line and not a hot line because we make a commitment to get back to you within 24 hours. If you forget any of these lines, we have lines for hepatitis C, for substance use, for post-exposure prophylaxis, for PrEP, for perinatal. Just Google it, AETC PrEP line, AETC substance abuse line. But if you forget any of that, as Kim knows, just call me and I will connect you with one of our clinicians. So this is the National Clinicians Consultation Center. You can see that it's Monday through Friday, 9 to 8 p.m. That's the warm line. And then here's an example for the PrEP line. If you do use one of our national lines, it will alert me that you contacted the line so that we do follow up with you. And so you'll get a nice friendly call from me saying like, hey, you had a call to the warm line about PrEP, or hey, you had a call about CMV. And so we do call you up later to say, like, would you like to do a rotation with us? Would you like to do another program with us? So I'm retiring June 27th, which I think is 22 work days away, will be my last day as a full-time employee. So I'll be an old age pensioner July 1st. Sometime in August, the university tells you when you can come back. Sometime in August, I'll be on callback, 43% time, and I've made a commitment to the people that are taking over to work at least until March 2025. I'll be a emeritus professor of family medicine at the UCLA Department of Family Medicine, and as I said, Kern County is a major love and priority. So this is just an org chart of the AIDS education and training centers within the Pacific region. You can see we have 8 performance sites. Los Angeles is just one of them. Kern County kind of falls into 2 jurisdictions. It's our Central Valley AETC in addition to the Los Angeles AETC, but we probably do more trainings here. So this is the old leadership with me at the helm and Sandra Cuevas as the deputy director. Dr. Artis Mo is one of our faculty. She's a provider both at UCLA and at Northeast Valley Health Corporation, which that's the closest probably to Kern. And so she does rotations there as well. We do have dental faculty, so all of the oral health trainings in our region come through UCLA. She and I have been working together. We just did a program last week around methamphetamine and oral health and HIV for Hawaii dentists. And then Dr. Butler, who's the head of our Drew site here, will be taking over from me. He's an HIV specialist physician. He's the chief medical officer of the THE clinic, To Help Everyone clinic in South LA. And so some people are moving up and over, so he'll be taking over for me. Sandra's going to be the director. Dr. Mo will still be with us, and Dr. Yunai will still be with us. We'll still be doing all of the oral health trainings. Dr. Takayama will be taking over at USC. He's one of the first providers giving PrEP in Los Angeles and actually did an NPR segment on PrEP monthly. So if people remember that, PrEP's been around since what year? 2012. So he's been a PrEP provider for over 10 years. And Dr. LaShonda Spencer, who has a specialty in women and children, will be taking over our Drew site. So that's the new team. And so every 5 years, the government changes the focus of the AIDS education and training centers. You can probably relate if you have federal funding or if you get state funding, any type of funding. Even though I've been really lucky that I've been able to raise my salary and the salary of those other people through different applications to lots of different funders, the only thing that's been consistent for the last 34 years is the AIDS Education and Training Center funding. But it doesn't mean it stays the same, right? It changes every 5 years or so. So we're approaching July 1st, starts a new 5-year cycle. So I'm just gonna give you a couple of the highlights. I'm gonna go through this quickly. We're going to have the same number of local partners within the Pacific, but there's going to be a lot of new focus and new sites. So there's something called interprofessional education. I don't know if you've ever heard of that, but we take pharmacy students, nurse practitioner students, medical students, psychiatric residents, and we rotate them together in Ryan White clinics. And so we've been doing that for the last 5 years in Los Angeles, but the new application says you have to do it in a new city. So we can't do it in Los Angeles anymore. So that's good in that it frees up some clinical training capacity at our Ryan White clinics that we can rotate other people through, but it's kind of sad because we loved our interprofessional education program. We won awards in, and I can show you videos, but I'll miss that program. We're gonna have new practice PT or practice transformation sites. That's working with a clinic where they identify a goal and you work with them over time. We're working with one clinic now to improve their PrEP referrals. And so we're working with them, a community college, and in the community college, we're working with the nursing programs and with hookup apps. And so we're making the ads for PrEP go through the hookup apps like Grindr, and there's a million of them, like there's 24 of them. And I'll just really share with you really quickly, Patrick already knows this, that with our program at the community college, we launched just about 3 weeks ago. I was amazed to find the nursing students, most of whom are straight young women, knew what Grindr was and could list 3 or 4 hookup apps at our information table, but didn't know what PrEP was. So nursing students at the community college don't know what PrEP is. And so another target is gonna be what are called minority serving institutions. And so UCLA is going to be a minority serving institution. We qualify for serving the Hispanic community. We're going to get that designation next year. Of course, Charles Drew University is HBCU, but also your community colleges. So Cal State Bakersfield is a minority serving institution, and Bakersfield College is a minority serving institution. So we're definitely looking to focus on our target within those programs will be the faculty. And so we're targeting the faculty to say like, hey, the nursing students don't know what PrEP is. How can we make sure you include it in your curriculum? And so Dr. Lyon helped me come on this journey with him. And so I think we did our first program, does that sound right, in 2019, where we launched the program here in Bakersfield. Kathy, I know, was part of that launch. And we've done many presentations since. I want to again thank him for being such a good partner. And you know, the Kern has a reputation, and it's a good reputation. And so we're videotaping this tonight, and I'll be able to edit this part out. But part of what I want to do is post this on our learning platform, and it's going to be some title like Providing HIV Care and Prevention Services in Rural California, Best Practices from Kern County. Because I think tonight is a really good example of like having Ashton talk about primary care, having Patrick talk about PrEP, having Dr. Lyon talk about emergency departments and rapid art. But like, you don't have to have a ton of resources. And I think one of my slides that I have up here, Kern County doesn't get EHE money, right? It doesn't get End the HIV Epidemic resources. But if that program were established today, some of the numbers Kim shared with you, you guys would qualify and would bump out one of the other California cities that does get EHE funding. So we've done lots of programs. I just pulled up some slides to show some examples where Dr. Peters, the medical officer for the entire state, welcomed everybody along with Dr. Lyon. And some of the things that we went through, and here you can see why Kern is not an EHE county. This is actually the agenda from the relaunch. And so we relaunched the emergency department project, and you can see here we have contingency management for stimulant users, a new Medi-Cal pilot program. Raise your hand if you know about that program. So just a handful of people know about it, but it's a really amazing program. We had behavioral health on from Kern County. You guys opted into that program. Incredibly important. Methamphetamine is such a driver of these epidemics, of these syndemics here. And so you could see it was, we also had the Dr. Bear, who does street medicine. And I just have to say that that's another example of where Kern is providing leadership. Raise your hand if you're from Clinica Sierra Vista. So we have a table of Clinica Sierra Vista here. Dr. Ayala trained with us, and so he's the chief, there you are, is the chief medical officer. And I think that it's another example of what can be done, especially in a non-EHE county. I want to say that it sounds better than rural because I know Bakersfield's a big city, but you had the vision of having multiple people within your institution pass the HIV specialization test so that you can take a vacation if you need to. There's somebody there who's a specialist who can take over. And I really think that's a model for other counties. And Clinica Sierra Vista has always provided that kind of leadership. And we had Anna Olvera to talk about the contingency management program. So we've done many, many presentations about the Kern success story. And I just have to say that these are the top 8 counties for newly diagnosed have EHE funding, and number 9, Kern, which would be in those top 8 now, does not get EHE funding. But you have an advocate in me and in the new folks to change that. And so that led to, Dr. Lyon already talked about the letter from Kathy Jacobson and from Marissa Ramos, the head of the State Office of AIDS. That letter went out to all emergency departments across the state, basically saying adopt the Kern model. So I seem to be missing a slide. Hold on. Okay, so what do we do? There was a slide that listed the types of trainings that we can offer you. So I know some of the people at Clinica Sierra Vista have gone through our clinical training program at USC. So that's like a kind of a cookie cutter program where you can come and do 1 or 2 weeks. You rotate with HIV specialists at USC, and you rotate at Ryan White clinics. Or you could do a specialized training. I believe, Dr. Raleigh, didn't you rotate with Dr. Moe? As a resident. So he was a resident and rotated with Dr. Moe at Northeast Valley Health Corporation. And in my opinion, that's one of the best trainings you can get because you're in a Ryan White clinic with a Ryan White provider seeing real life issues day to day. But we can also do, COVID happened and we didn't stop doing training and technical assistance. So that entire relaunch was done online. We can help you connect with resources and courses. I believe the providers used the AETC national curriculum to study for the specialization exam. I know that Ashton shared with me, she also used that national curriculum to study for the exam. We can connect you to resources around a special population. We've done trainings with Patrick targeting around special populations like transgender on HIV testing day. I remember we did something for working with trans patients. We do a lot of work around methamphetamine, a lot of work with immigrants. So whatever HIV-related need, I say stump me, give me a call and say we have this need, what can the PATC do for us? So I hope that kind of outlines, what an AIDS Education Training Center does, its clinical training, its programs in the community, its resources, but we're here to support you guys. Thank you.
All right. Well, thank you all for joining us tonight, and thank you very much to our speakers who provided what I hope you find very helpful information tonight. On your table, you will find a folder, and in addition to a printout of all the slides, you'll find some helpful information, some of which was mentioned in Patrick's presentation to refer to, but you're also going to find a post survey and an evaluation form. It would be extremely helpful to us if you can complete both and leave them on your table before you leave. As was mentioned earlier, we are planning to have quarterly healthcare provider symposiums, and so the evaluation will really help us understand what topics you want us to cover, how we can do this better. Any feedback that you want to give us, we would love to have so that we can continue to provide these, but in a way that you guys want to receive that information. So that would be extremely helpful to us. We also have included on your table our new catalog, and this is a catalog of all the services that public health has to offer. So in addition to all of our HIV services, I would encourage you to look through the catalog, and if you have any patients that may benefit from some of the services that public health has to offer, please feel free to send them our way so that we can together help to serve our community. With that being said, again, I'll just ask you to fill out those forms, but we really appreciate you spending your evening with us and hope that you enjoyed the content that was shared with you all this evening. So thank you very much.